Okay, welcome back. We've got two chapters to cover in this particular video. We're doing premium sensitivity of health insurance, and then the other one that we're going to do is called Compensating Differentials. And the first one is about, it introduces employee-sponsored health insurance. If you remember from previous chapters, we've already talked about this, and we said that over 60% of the U.S. population under the age of 65 get their health insurance from an employer. The power of three words for this week for the premium sensitivity chapter are, of course, the word sensitivity, take-up rate, offer rate, and eligibility rate. The next chapter is called Compensating Differentials. And what that's really getting at is how employees are paid for their services that they provide and how they're compensated for the work they do. And there's a funny little cartoon right here, and the toothbrush says to the toilet paper, "Hey, sometimes I feel like I have the worst job in the whole world." And the toilet paper says, "Yeah, right." The power of three words or group of words that are associated with this particular chapter are marginal revenue product, to make the employee whole, and out-of-pocket premiums. This chapter emphasizes Welch's research along with other researchers, and the finding was that there's a greater willingness to change plan dependent upon the number of plans that the employer offers. So if there's a lot of plans, there's more apt for the employee to change. Also, another important component is the availability to the household to get insurance either through a spouse, a parent, or from a public program. Alright, this chart, which is also in your book, shows the number of disenrollments as relative premiums go up $5 at $5 a clip. Now it's pretty sizable, and it's a lot of disenrollments per 1,000. So I want you to take that with a grain of salt. The reason I say that is as the chapter goes on, it talks about how some employees have other methods of getting insurance: spouse, parent, Medicaid, state children's health insurance plan, which probably means that those particular workers in this particular study are not making as much money versus someone that's got a high salary. You raise it $5, they're probably not going to disenroll from the plan. This chart comes from Feldman's research and really is one of the first that deals with the availability of substitute sources of coverage outside an employee's own firm. As you can see, if you look at the HMO as a small player or only have a small percentage of the business, any increase at that point is going to be a substantial loss of enrollment to other HMOs. As you move down the column, and you can see that as a HMO becomes the dominant player in the business, they only lose enrollment to conventional plans, and they're declining competition from conventional type of plans. Thus, as they move across the row, they decline enrollment shares are smaller and smaller. The last chart in this chapter comes from Buckmuller and Feldstein in what I would call a set study, where in 1994 the University of California changed its health insurance system, one that was set on the four most popular plans, and they came up with an average to where they pegged it at the least costly plan. And so in the new plan, if employees wanted the least costly plan, they paid nothing out of pocket. However, if they wanted the more expensive plan, they had to pay an employee premium contribution equal to the entire difference in the premiums between the chosen plan and the least costly plan. This chart shows the changes as premiums increase by $10. At no increase, at zero, you can see the two are sitting at 5.2 and 5.2 for all and HMO only, but that's probably because they made changes for other reasons than price. Then when you change price, however, 26% of the employees changed plans when faced with a 10% increase in premiums. And then when they got up to $20 and another increase of $10, they're up to 30% will change because of out-of-pocket increase in premiums. Talk a little bit about some of the rates for the employers and the employee. The author rate is the proportion of employers offering insurance to their workers. Then you have what's called the eligibility rate, and that's the proportion of workers eligible for insurance coverage. And then finally you have the take-up rate, which measures the proportion of eligible workers who accept coverage through their employer. Why has coverage for employees fallen? So fewer employers are offering coverage is one thought, fewer workers are eligible for coverage, and then fewer eligible workers are taking up coverage. So there's a number of reasons for it to drop off, and if you read the paper or read some of the latest journal articles about the Affordable Care Act, many individuals have their thoughts about why the rates are starting to drop. Alright, so if you look at this chart, you can see that the take-up is going down, that employee-sponsored coverage is declining, largely due to employees not taking the insurance when it's offered to them. Let's look at some more recent articles. If you go to the web and you look up healthcare reform and the shift to part-time workers, you'll see that there's a lot of different opinions, a lot of different research, and a lot of different takes on what's happening with the ACA. But one suggestion is to change the threshold to make full-time workers 30 hours from 40 hours. But according to this article right here, it says that only 8% of the workforce is represented by people that work 30 to 34 hours. So in fact, if you change it and you make all these people full-time, they're suggesting that this may increase the likelihood of more part-time workers. So consider that if you're an employer and you have 50 full-time workers, you then have to have health insurance, and so there's an additional cost to a business. So they may actually go to more part-time workers, which hurts those ones at the 30 to 34 hour level by making them full-time, and so it can change the dynamics tremendously. An article that came out in Forbes magazine just before the loopback provision was supposed to go into effect, and if you're not familiar with the loopback provision, it's part of the Affordable Care Act that sets the baseline for this year for the number of full-time employees that a company can employ to determine their compliance with the employer pay or play mandate, which basically at this point it's 50 employees. If you have 50 employees, full-time employees, you have to in turn provide health insurance. If not, then you could be fined $2,000 to $3,000 per employee per year. So that's a big concern, and it did get extended another year. But here's some of the quotes that were in this article that's worth sharing. Goodrich, the owner of 21 Subway franchise, said that he has no choice but to cut hours for his employees to 29 hours a week to avoid the law's penalties. So people are coming up with problems with the new Affordable Care Act, and it's a question, is it really causing that many people to end up getting part-time jobs? And the discussions go on and on. So it might be worth talking about in a Power 3 discussion in your group. Next section goes over key topics regarding employee-sponsored health insurance. Who pays for coverage, and why employees commonly get health insurance through their employers. The big takeaway from this particular chapter is that the general view of microeconomics is that workers are paid what they're worth, and the payment can take many different forms. So why do employers sponsor health insurance? For one, the employees value the coverage, and in most cases, well, probably in all cases, it's cheaper for the employer to purchase the policy than for an individual to go out directly for tax benefits and administrative costs and the ability to negotiate. This slide goes over some of the implications of having employee-sponsored health insurance. When companies are forced to have health insurance or provide health insurance, this can lead to lower wages or reductions in other benefits. Changing tax rates also has serious implications. If you raise taxes in certain areas, companies may shift income in other places, which may or may not be helpful to health insurance. If they can avoid taxes by providing health insurance, they may do so, but it could work against them too, because they may shelter money in other directions that are not beneficial. Understand wage health insurance trade-off. You have to understand all of the benefits and all the compensation that the employee receives. This was a measurement called the general form that Miller used in his study. This chart comes from Jonathan Gruber's research, where he looked at wage health insurance trade-offs. He investigated the effects of the state insurance mandates for maternity benefits. So what he did, he called it the differences in differences in differences, or the DD analysis. He compared the change in wages before and after the enacted date of the laws, difference 1, and then in the states that did not enact the law, difference 2, and for people who would or would not be affected by the law, difference 3. The idea is that the wage changes in the unaffected states and similar but unaffected individuals would be controlled for by other factors at work in the states and the local markets. The results are interesting. If you look at the top of the chart, the married women aged 20 to 40 in states that enacted the law had wage decreases of 3.4%. Married women ages 20 to 40 in states that did not enact the law had wage increase of 2.8%. Let's take a look at age-wage profile. Over the life cycle, wages rise rapidly in the early years of an individual's career and then tend to flatten out as the person gets older. This is usually explained as wage compression, in that in the later years there are fewer increases in productivity. As you read through this chapter, you can see that Shiner argues that we can look at these age-wage profiles across different geographical labor markets. And in some markets where health insurance costs are high, in others they're relatively low. Applying age-wage profiles, you would see that in areas with lower wages for certain markets, there's going to be an offset with higher insurance costs. Also worth noting is that it's going to be more pronounced for older workers because they are likely to have higher claims experience and because the trade-off is less likely to be masked by changes in increased productivity. The increased spread between the curves reflects the differing compensation wage differential across markets. This chart shows the increasing magnitude of compensating wage differential as men age. The point that this author is trying to make when he describes this research is that the change is actually too large to only reflect healthcare costs. The book talks about the Cafeteria style benefit plan, which covers a variety of different types of insurance, but basically it gives workers credit allocation to spend on benefits, and I'll give you an example here in the next slide. If you look at this slide, this is an example of the Cafeteria style benefit plan, and it's on a sliding scale based on the employee's wages. So they can buy life insurance, long-term disability, accident insurance, dental insurance, etc., and they can allocate a certain portion of their pay towards that based upon this particular Cafeteria style plan. We're coming to the conclusion. That was 2 tough chapters. So, in conclusion, results suggest that employees respond to higher premiums by lowering their level of insurance coverage. They also absorb some of the increased price by lower take-home pay and by cutting other benefits. Results suggest that employers are doing the right thing, substituting wage increases for insurance premium increases. All right, be careful out there.